We are live, sir.
Okay. Can I start?
Dr. Ketan, 7:30 will start. We'll
Okay.
wait for a minute. 7:30.
Okay, Vivek, it's 7:30.
Yes, sir, we can start.
Okay. So thank you, Vivek. So on the behalf of Conquer, the division of MQ Pharmaceuticals Limited, I, Dr. Ketan Kulkarni, from the medical team of MQ Pharmaceuticals Limited, welcome you for this webinar. So the topic for today is diagnostic challenges and current prep options. So today we have speakers, Dr. Dipankar Pal. So Dr. Dipankar Pal has a family exigency, so I'll be presenting his slides, which he has already shared to me. We also have got Dr. Abhishek Sengupta sir, Dr. Uh, DC Modak madam, and Dr. Prasanna Kumar sir as the panelists. So we have speakers, Dr. Dipankar Pal, whose slides will be presented by me, and Dr. Abhishek Gupta sir. Panelists include Dr. DC Modak and Dr. Prasanna Kumar sir. So coming to a short introduction for the speakers. So we have with us today Dr. Abhishek Sengupta sir, who is a MD in microbiology, and currently he is a assistant professor, infections control officer and unit in charge, and also the helminthology unit at the Department of Microbiology, School of Tropical Medicine, Kolkata. Dr. Dipankar sir, who could not join today, but still I'll give a brief introduction. So he's the Assistant Professor, Department of Infectious Diseases, School of Tropical Medicine, Kolkata. Dr. DC Modak madam, who is the Associate Professor, Department of Tropical Medicine at the School of Tropical Medicine at Kolkata. And we have got Dr. Prasanna Kumar P, who is the Associate Professor, Department of Infectious Diseases at the Christian Medical College, Vellore. So, on behalf of everyone, I like to invite all the faculty today. So, the scientific program includes the first speaker is Dr. Abhishek Sengupta sir, who will be speaking on HIV diagnostic challenges, followed by current prep recommendations. I will be sharing the slides on Dr. Dipankar Pal's behalf, and later we'll have a panel discussion with Dr. DC Modak, Dr. Prasanna Kumar, as well as Dr. Abhishek Sengupta sir. So, with this, I'll hand over the session to Dr. Abhishek Sengupta sir to present on the topic HIV diagnostic challenges.
Thank you, sir.
Thank you, sir.
Yeah. Is my slide visible?
Yes, sir.
Yes, visible.
Okay. Thank you, everyone. I would thank MKO to give this opportunity for me to present a very interesting and never-ending topic today. So I shall be picking up a few aspects on the diagnostic challenges of HIV infection. So when we go for a diagnosis of HIV infection, we need to understand what are the objectives for testing. So the objectives for HIV testing predominantly remain transfusion and transplant safety, diagnosis of HIV infection in symptomatic and asymptomatic individuals, prevention of parent-to-child transmission in cases of post-exposure prophylaxis, epidemiological surveillance using unlinked anonymous HIV testing, and of course, in the end, for research purposes. So before even we start to go for diagnosis, we have got certain mandatory prerequisites for testing for HIV. So we have to ensure a proper and timely pre-test counseling is done. The entire process is explained to the is to the subject, and it's only after obtaining a proper informed consent that we can go about the testing process. Whenever we go about the testing process, we should be able to identify the person using at least 2 identifiers. That would include the name, identification number, age, or gender of the person. It's not just one. When we get the results, it's also very important to maintain the confidentiality of HIV testing results, and they need to be shared to the subject themselves, with ensuring that proper post-test counseling is also done. These are certain steps which are followed meticulously in our ICTC and ART centers as well. Now, when we go in for testing, the main modalities of testing that are available for us is serological testing. And then we go in for confirmation or for prognosis of already diagnosed cases. We have the molecular analysis and the CD4 enumeration tests. So what are the samples that we need to choose for the different diagnostic modalities? So for serological testing, we can go in for serum, plasma, or whole blood. The sera can maximum be stored at 2 to 8 degrees centigrade for up to a week. And if you have to go for longer storage, like in smaller centers, then the specimens need to be kept frozen at minus 20 degrees centigrade. When we are going for CD4 enumeration tests to assess the CD4 count in a patient of confirmed HIV diagnosis on treatment, what we basically, the sample that we essentially need is whole blood collected in EDTA vials. And the samples need to be processed immediately. And if there is a concept of storing, they need to be stored at ambient temperature for a maximum of 48 hours. So these are certain challenges which should be kept in mind. And another point with respect to CD4 estimation is that CD4 has got a diurnal fluctuation. So we should try and maintain the sample collection time essentially whenever we are going in for CD4 enumeration assays. The other aspect is the molecular assays for DNA or RNA PCR, where the available or the options for sample collection would be DBS or dried blood spots, whole blood collected in EDTA. And whenever you're collecting the plasma for a molecular assay, it must be separated within 6 hours of collection and stored at minus 20 degrees centigrade for further processing. Just like any other infectious sample, HIV sample, if it is to be sent for higher centers for further diagnosis, it has to be following the IATA regulations, because HIV falls under UN class 6.2 specifications. That is following, as this is already something which is known to you. It's a triple packaging system where the primary sample is to be kept in a primary receptacle, which is to be covered with some packaging material, which is to be kept in a secondary receptacle where the list of contents are to be mentioned, which need to be finally kept in a tertiary receptacle on which a biohazard symbol, the UN packaging certification mark, the consignee details, and the consignment number, everything needs to be shared. So first of all, we go into the options for diagnosis that we have, and we go across the challenges that we face as well. So serological diagnosis is the initial mainstay for diagnosis of HIV. We are primarily looking for antibody detection. The options that we have, of course, is ELISA, rapid tests in immunoconcentration or dot blot assay, which is your vertical flow, agglutination assays, immunochromatographic assays, which is your lateral flow, dipstick and comb assays, which is based on EIA, and of course, your Western blot for confirmation. So the serological diagnosis, what we have is, if we consider the generations, there are 4 generations for serological testing: first, second, third, and fourth. And when we have the 4 generations, first is the antigens coming from the HIV lysates, which lacks sensitivity and specificity. We move up a step in second generation, where we use the recombinant proteins and or synthetic peptides, which enhances the sensitivity. One step up, we go to the third generation, where we are using recombinant proteins and synthetic peptides. The advantage is that we are enhancing the sensitivity and specificity and also able to detect IgM antibodies, thereby reducing the window period. And we go one step up where we are going 4th generation serological testing, where we are detecting both the HIV antigen P24 along with both the IgM as well as the IgG antibodies, thereby further reducing the window of detection. ELISA remains the mainstay. This is the basic principle of ELISA. We already know how to go about it. We won't go into details of this particular diagram over here. What are the applications or what are the types you have? First is an indirect ELISA, where we are using an antigen coated well to which the patient sample is added, which of course might or might not contain the antibody. And if the patient is infected, the antibody gets tagged to the antigen, and then by a system of conjugate substrate, we are able to detect the OD values and we are able to confirm the diagnosis. Another option that we have is competitive ELISA, where we are simultaneously pairing in the patient sample as well as the known conjugated antibody, which compete together for binding on the antigen coated well. So this actually gives a reverse result. That is, if you are getting a high OD value with a signal, then that is indicating absence of HIV infection. And if you're getting lack of signals, that is indicating HIV infection. So the advantage is that it takes less time. To improve the sensitivity, we can go further steps by going for antigen antibody sandwich ELISA, where the patient's antibody from an infected patient is sandwiched between 2 antigens on either side. The second antigen that we are adding is containing the conjugate, which combines with the substrate to give the color. So that enhances the sensitivity and specificity of the indirect ELISA. Another format that we have is the antigen antibody capture ELISA, which is the most standard ELISA that is used, in which case we are reversing the situation. We are having an antibody coated the ELISA well, where an antigen is added to it, and then the patient sample is added. If the patient is infected, the antibody gets tagged to the antigen, which is bound to the antibody on the well. Then we similarly add a substrate chromogen complex to enhance the specificity of detection of this ELISA. The advantage that we have with the capture ELISA is that low concentration titers are detected, and also we are able to detect certain specific classes of antibodies for HIV. Now, what are the challenges that we face when we do routine serological testing, most commonly ELISA? So we divide it into a pre-analytical, analytical, and post-analytical. In the pre-analytical stage, we can get hemolyzed sample, which is going to interfere with the results. Grossly lipemic samples. There's a habit of repeated freezing and thawing of the sample before testing, which again can lead to discrepancies in the reading. Contaminated samples and reagents, which are very neglected but very dangerous which can have a very dangerous consequence on the reporting, and the lack of proper quality control practices, which can lead to deterioration of the reagents. In analytical stage, there could be pipetting errors on the part of the technician performing the test, improper incubation time and temperature. Every step of ELISA has got a proper temperature and proper timing of incubation for the antigen and antibody to bind between themselves or to the substrate. So if that is not followed properly, again, it will give rise to aberrant results. Improper washing procedure. Carryover from adjacent specimen. This is most commonly seen in those labs which are doing manual washing. Equipment malfunction. The use of glove powder aerosol, and calculation errors where kit inserts are not always followed in deciding or calculating the OD values. And post-analytical, this is common thing with any lab parameter, not just HIV, that is your transcription errors. So these are some of the challenges that we should be very stringent upon when we are going in for diagnosis of HIV by ELISA. False positive results are commonly seen in several autoimmune diseases, cases of alcoholic hepatitis, primary biliary cirrhosis, leprosy, and several multiple pregnancies. And false negative results can be seen with technical errors. And of course, the test is in the window period that can give rise to a false negative results. Next, we have a battery of rapid tests which are available, which is done prima facie at the diagnostic centers in ICTC. That is your immunoconcentration techniques or dot blot immunoassay or vertical flow, where this is a type of solid phase immunoassay where the HIV antigens are immobilized on a paper. And it's classically known as the tri-dot, which is giving not only HIV-1 diagnosis, but also HIV-2 diagnosis as well. Immunochromatography, you're simply converting the vertical flow into a lateral flow where on a nitrocellulose strip paper, the HIV-1 and HIV-2 antigens are incorporated. So if the patient is infected, we again get distinct bands, which will tell you that this is an HIV infection plus minus or an HIV-1-2 infection. Particle agglutination test is not that commonly employed, where you are converting an agglutination test into a particulate agglutination test by tagging these with carrier particles like red cells or latex particles, and you can get a diagnosis of HIV. It's a rapid test as well. Immunocomb assay, which is known as the Comb assay, this is a .ELISA or .EIA actually. This is very commonly done in several ICTCs where both HIV-1 and HIV-2 antigens are immobilized as circular spots at the two sites. And the third spot is obviously acting as the control, where you can get a diagnosis of HIV as well as HIV-1 and HIV-2. Again, the challenges that we must remember with respect to the rapid tests is with respect to the sensitivity and specificity. And that's why whenever we are going in for the use of rapid tests, we will discuss with the strategies. We need to go in for a combination of several tests to arrive at a final diagnosis. And every kit needs to be monitored from time to time, especially for quality control practices with respect to several NABL parameters. Now, Western blot is where the specific HIV-specific antigens are adsorbed onto a nitrocellulose paper. And this is a highly specific test, serological confirmatory test, which is usually done in the referral centers for confirmation of indeterminate serology reporting reported by the ICTCs. So overall, the challenges of serological testing remain antibodies being not detectable in the window period, though fourth generation tests have solved this problem to a great extent. And second is the utility of these tests being challenged in antibody detection for diagnosis of HIV infection in children below 18 months of age, where the gold standard for diagnosis still remains molecular assays. Now, shifting to the molecular assays, the mainstay is in the diagnosis of pediatric or HIV infection below 18 months of age, because usually there is a persistence of maternal antibodies in the infant's blood till 18 months after birth. We resolve to HIV-1 DNA PCR, which can start at 6 weeks of age or at the earliest opportunity thereafter. And the other application of molecular assays is in detection or confirmation of acute HIV-1 or 2 infection, where positive NAT results confirm the HIV diagnosis. We can go in for qualitative detection of HIV-1 DNA or RNA, but more importantly, upon a diagnosis, we go for quantitative detection of HIV-1 RNA, which is your viral load estimation. So qualitative PCR for HIV DNA is predominantly for diagnosis of pediatric HIV-1 infection. Several options are available. The Amplicod HIV-1 DNA PCR test. DBS is a sample in addition to EDTA with a very high sensitivity and specificity of these tests. Qualitative transcription mediated amplification is the Aptima HIV-1 qualitative RNA assay, which is also available. And the quantitative HIV-1 RNA assays are predominantly the reverse transcriptase PCR, that is your RT-PCR, real-time PCRs, and nucleic acid sequence-based amplification assays. We also have the options for the branch chain DNA technique, and they are mainly used to determine the viral load. Virus isolation is something that's mostly in the research stage, where HIV isolation requires co-cultivation of peripheral blood mononuclear cells of an infected individual with non-infected individuals are cultivated simultaneously in a medium containing interleukin-2 and maintained at 37 degrees centigrade and 5% CO2 for up to 28 days. And the replication of HIV can be detected by measuring P24 antigen by ELISA or the estimation of reverse transcriptase activity in the culture supernatant. But as you can understand, that is extremely labor intensive, time consuming, and till date, this continues to remain a research tool. Antigen detection is an option. Is the positive P24 antigen does confirm the HIV diagnosis, but again, a negative test does not rule out HIV infection. Of course, we know that its estimation is done based on ELISA, especially 4th generation ELISA. Now, when we go for strategies for HIV testing, whenever that's applied all across the country, the objectives are that the testing should be part of an overall comprehensive prevention program. Testing should be technically sound and appropriate. The testing procedures must be field appropriate. The testing procedures must be cost effective, and the lab procedures must be monitored to ensure quality. The national testing strategies are applied for blood or organ donation safety, for surveillance purposes, and of course for diagnosis purposes. We are all familiar with the testing strategies. I would just like to go through it once again. The NACO's testing strategy 1 is for transfusion or transplant safety, where a single test is required. It's a highly sensitive and specific test, on the result of which you can declare it as positive and negative and act accordingly. In strategy 2A, this is for an unlinked surveillance purposes, where you do a test 1. If it's negative is concerned, that's negative. But if it's positive, you subject it to a second test, which of course is one with a higher specificity compared to A1. And if both are coming out to be positive, it is reported as positive. But if obviously A2 is coming out to be negative, then it is reported as negative for surveillance purposes. Strategy 2B is meant for diagnosis of an individual with AIDS indicator disease symptoms, where again we begin with a highly sensitive test A1, which if it is negative is reported as negative. But if it turns out to be positive, we do a second test, that is A2, with a higher specificity. And if both the tests come out to be positive, it is reported as positive with post-test counseling. But if there's a mixed bag result, we subject it to a third test, which is a tiebreaker test, where again, if two tests report a negative and one a positive, then it is reported as negative. But if two are reporting positive and one negative, it is labeled as an indeterminate serology, where the idea is to repeat it after 14 to 28 days or subject it to confirmation by Western blot or PCR. Strategy 3, which is the most common strategy followed for detection of HIV infection in asymptomatic individuals in the ICTCs, etc., where it's a 3-test strategy which is required. Again, if A1 is negative, it is reported as negative. But if it turns out to be positive, irrespective, we go for a test that is A2. So we have now a combination where A1 and A2 can be positive, or A1 positive and A2 is negative. In either case, we have to subject it to another test, which is called A3. So the outcome is we can get all the 3 tests to be positive, which is reported as positive with a post-test counseling. If one of the tests, that is if A3 turns out to be negative, then it is taken as indeterminate. Or if A2 is also come out as negative, then also it is termed as indeterminate, and this repeat serological testing is done after 14 to 28 days. But if A1 comes out to be positive and A3 also comes out, A2 and A3 come out to be negative, then we assess the risk status and we can determine either it as indeterminate or as negative for the patient. And we already know that assays A1, A2, and A3 are chosen in such a way that the tests have got different principles or different antigens which are used for HIV testing. As a rule, the first test that we apply, that is A1, is obviously one which has got a very high sensitivity, and A2 and A3 have got a very high specificity to, and should also have the ability to differentiate between HIV1 and HIV2 infections. In the strategy 1, which is done in case of or practiced in case of donations, if it comes out to be positive, we have to refer the patient to the ICTC and take a decision from there. And as we have seen that if the results turn out to be indeterminate, then the repeat serological testing is done after 14 to 28 days, following which it is subjected to Western blot or PCR. Diagnosis of HIV2 is an interesting condition where we have tests now where we can, even in rapid tests, we can arrive at an initial diagnosis of HIV2. But if HIV2 is diagnosed in the ART center, you have to refer the patient to a designated HIV2 referral laboratory, because we know that the treatment modality of the two infections are different. Where in the HIV2 referral laboratory, fresh blood sample is collected in an EDTA vacutainer, and it is tested as per the national algorithm for HIV2 serodiagnosis. And then the report is sent back to the ART center, and the ART center then mediates the treatment of HIV-2 in such cases. The final aspect remains the tests which are there for monitoring the stage and progress of HIV. So first, what we have is the immunological test, that is your CD4 T cell enumeration, which essentially is a hallmark clinical surrogate marker. Its facility is also the ease and low cost. And the virological assays, that is your HIV RNA load assays, which essentially is trying to measure the cell-free virus in plasma, and it's the clinical standard of care and monitoring for managing the response to ART. Other options would be to go for measurement of HIV P24 and the reverse transcriptase activity assay. So we have got several approaches to that for molecular diagnosis. The Amplicor HIV of Roche, where we are taking plasma and we are detecting the group M, the targeting the GAG gene. The Cobas-Stackman is targeting the GAG gene again. The real-time HIV-1 of Abbott, which is targeting the Pol gene. The NucleSense HIV of bioMérieux is targeting the GAG gene, and the Versant HIV-1 of Siemens is again targeting the Pol gene. So these are basically used for HIV RNA viral load assays to assess the prognosis in patients on ART. So with this, I would like to conclude my initial presentation and hand over to the presenter.
Thank you, sir, for a very lucid presentation. Just Dr. Dipankar sir has joined, so maybe.
Hi, Dr. Ketan.
Yes, sir.
You probably have already heard that my relative, one of my very close relative, is in ICU. Currently, I am sitting in the ICU. We
Okay.
just intubated him a few hours before, so I could not finish up and give all the slides that requires much more elaborative discussion that I sent it to. Can you please, on behalf of me, just the summary slides I have sent to you, just discuss those slides. And I also requested Dr. Prasanna Kumar and Dr. DC Modak, the panelists for today's discussion, they can summarize and give the take-home message in brief. That will be really helpful.
Yes, sir. So I should present the summary slide, right? Hello? Hello?
Yes. Only the summary slides, 12 slides I have
Yes.
sent. The
Yeah.
means not the summary, means total 12 slides are there, but
Yes,
because
yes.
the entire presentation consists around 40 slides, that is difficult because the various studies are there that need some elaborative discussion. That is not possible at this
Understood.
point in time. So the main slides I have sent to you. Just I skipped those studies that I have made. So can you please continue as the audiences have already joined from both from India and abroad. So just on behalf of me, can you please discuss those slides, and Dr. Prasanna will summarize and give the take-home message.
Right, sir. Right, sir. So I have received your slides, sir, and thank you very much for joining. I understand it's an important situation for you. So thank you very much for joining as well, sir. Thank you so much. Okay.
Thanks.
So I will present the slides on behalf of Dr. Dipankar Pal, sir. The topic is PrEP, current recommendations. So the speaker for today is Dr. Dipankar Pal, who is from the Department of Infectious Diseases at the School of Tropical Medicine, Calcutta. So he has some family issues and could not take the session, but he had joined for a minute or so, though there is a very crucial family exigency. So on his behalf, I'll be sharing his slides. So over 1.3 million new over 1.3 million new HIV cases are there annually worldwide. And most important risk of transmission is uncontrolled HIV with high-level viremia in the source. So the most effective prevention strategy is test and treat. And acute HIV and recognized HIV contributes disproportionately. And initially, as you all know, there is acute HIV, then early HIV, followed by the AIDS, and followed by the chronic infection. So there are behavioral and biomedical preventive strategies which are available. And undetectable viremia is a goal, but at least less than 1,000 copies is desirable to stop the transmission. So this is a slide which has the different types of sexual exposures. You
There
can
is,
see
sorry, Dr. Kulkarni, there is this probably the pattern of the presentation, the slides, probably this might have changed.
Right.
That that probably not went well to, that have not reached to you. Just you can skip this slide.
Yes. Okay. So PrEP, it reduces transmission by more than 99%. Breakthrough infection does occur. And repeated mucosal injury with high viral loads in the source breakthrough with PrEP is there. And condomless anal sex has the highest sexual risk. So these are the options like TDF, FTC, 300 and 200, or TAF plus FTC, that is 25 milligrams of TAF and 200 milligrams of emtricitabine. Injectable cabotegravir long-acting is available globally, and also injectable lenacapavir. These are the options. This is for MSM for daily PrEP. So the preferred drug is TDF plus FTC. It has got extensive experience, but there is a caution for kidney and bone diseases. Here, the condoms are used for initial 7 days to achieve adequate concentration in the genital skin. And double dose that is used in the first 48 hours quickly achieves protective drug concentration, and duration is as long as the person remains sexually active. For transgender persons, it is similar to MSM population. So daily TDF, TAF plus FTC. It is event driven. Transgenders were not included in the hyper-gay trial, so they may be used with discussion. Exogenous estrogen reduces TDF level. That is a point to remember. And still, it is event driven and may be practiced in anal, but not in vaginal sex. For intravenous drug users, so daily TDF FTC is approved. So TAF and emtricitabine and injectables are not tested in these populations. So you have to start at least 7 days pre-exposure, and some prefer to use it for 28 days. So if the eGFR is between 30 and 60, TAF and FTC is reasonable option. And TAF has got higher peripheral blood mononuclear cell concentration than TDF. So this is for vaginal and frontal sex. So daily TDF and emtricitabine is preferred in cisgender women. TAF and FTC, there is insufficient data for use in vaginal sex. Sexual activity for 7 days and 21 days. So to achieve protective TDF level, double dose like event-driven PrEP is required. Another thing is that event-driven PrEP is not recommended. If the eGFR is between 30 and 60, you can give TAF and FTC, cabotegravir long-acting preparation. And if the eGFR is less than 30, also you can give cabotegravir long-acting. Injectables, lenacapavir. So lenacapavir is one of the new kid on the block globally. So it is a long-acting capsid inhibitor. A dose is 6 monthly by subcutaneous route. So for PrEP, it can be used in MSM, transgenders, and cisgenders women. It reduces HIV infection by 96% versus the background rate. So more, it was in the study, it was found that it was more effective than TDF and FTC because of the oral adherence issue in the purpose 2 study. It can be used in around 5,388 adolescent girls and young women in cisgender population. So lenacapavir, it outperformed both TDF, FTC as well as TAF and FTC, and there was no difference between the TAF and TDF group in the purpose 1 study. So also a new study by Joguraju V et al. It states that once yearly intramuscular lenacapavir phase 1 also showed some promise. This is the another drug that is cabotegravir long acting. So it is 30 milligram once a day for 4 weeks leading, followed by 600 milligrams intravenous luteal injection with a 2-inch needle monthly for 2 months. So once it is a once week post injection, it reaches a protective level, and later on it can be followed up by 2 tablets of TDF FTC once a day for 7 days. Maintenance is 8 weekly injections. So there are some interactions with rifabutin and other potent UGT1A1 inducers. It has a long half-life, caution on sexual activity on discontinuing cabotegravir long acting is there. Now we go to PrEP discontinuation. So if the positive partner achieved stable viral suppression, that is less than 200 copies per ml in blood uh, after more than 6 months of ART, monogamous relation and regular ART by the positive partner, and then continue PrEP for some time after the last sexual act, and there should be HIV testing at the end of PrEP discontinuation. Oral PrEP, cisgender in and also MSM for 2 or more days after the PrEP last dose. Others say that 7 days post high risk sexual behavior. Caution is to be advised if there is a hepatitis B virus positive inactive carrier and HBV flare. So injectable PrEP detectable but non-protective levels of cabotegravir for 6 weeks, 6 months, and oral PrEP or condoms for 6 months who continues high risk sexual behavior. So to summarize, timely initiation and adherence is highly effective option for prevention of HIV. Pre-exposure HIV testing is mandatory. The most effective combination is emtricitabine and TDF. So lenacapavir is a promising drug and it is available widely across the world in the few countries. And definitely it will reduce the HIV incidence in all potential candidates. Lenacapavir has better pharmacokinetics than cabotegravir long-acting. So these were the slides which I presented for Dr. Dipankar Pal, sir. Thank you for your kind attention.
Can I please request Dr. Prasanna and Dr. Modak to just summarize and give the take-home message, please? Dr. Prasanna.
Okay. Thanks for the presentation. I'll just briefly summarize for especially for Indian settings, even for other settings, maybe the viewers from other countries as of now. So of late, recently, even the government of India, NACO, sorry, is the okay. NACO has endorsed a policy for PrEP initiation in India also. So even the government endorses now that because TB per se treatment will not stop transmission or the prevention. Now we are moving towards elimination. So there is a need for us to even undertake more than what is offered as a treatment to all HIV patients. We need to prevent HIV occurrence or the incidence. That's one of the thing to looked upon is your behavioral. The other thing is structural. Another one is a biomedical, where we come across these kind of PrEP initiations, which are widely accepted and used in most of the Western countries, not well established or used in Indian settings. As discussed, there are ways, there are drugs, approved oral drugs, which are currently available in India, tenofovir, emtricitabine, and there are 2 different formulations. One is disoproxetil, another one is alafenamide. Both are approved for these dual combinations. Both are approved for PrEP initiation. The government has extrapolated data for emtricitabine to lamivudine also. So Indian government has given recommendations to even add even lamivudine based tenofovir disoproxetil lamivudine or tenofovir alafenamide and lamivudine also you need to give. It's just interchangeable. So all these 4 drugs currently available in India can be used as PrEP for Indian settings. As of now, we don't have access to injectables, both cabotegravir and lenacapavir in India. We are hoping soon they will be made available. But as of now, these 4 drugs, any of these you can prescribe. That basically depends on the high risk behavior of the patients. So the assessment of the high risk behavior basically boils down to their sexual orientations. The highest risk would be MSMs followed by transgender women, where there are more often all the studies have looked up. You can use any of these 2 formulations also. Any of the formulations are considered okay for both MSM and transgender women. But in case of cisgender women, it's only tenofovir disoproxetil is recommended because we don't have much of studies based on alafenamide. So broadly, what you can understand is tenofovir disoproxetil, you can use dual regimen, either lamivudine or emtricitabine is a go-to drug for across any of the high-risk behaviors, including injectable users. Alafenamide, you can use only, as of now, the data is available for MSM and transgender women, not yet for cisgender women. So you need to be careful about it. Other problem with especially disoproxetil formulations are whenever the patient has underlying kidney problems, especially CKD, then you need to be very careful. If the creat clearance is not above 60, then we need to look for alternatives. Then up to 30, you can go for alafenamide. But somebody with a creat clearance of less than 30 without dialysis, then it's really an issue for us. We don't have, none of these 2 drugs can be used in Indian settings, especially in a CKD without a dialysis. But all other situations, we can use any of these drugs now. Other thing to look upon is that adherence. The basic understanding is one is the initiation, other is the adherence. These drugs have proven to be effective only if you are adherent to the therapy. If you are adherent, well, about 98%, the effectiveness even drops, goes up to 95 and to reach 100. But if there is a adherence issues and if there are interruptions, their effectiveness falls drastically, even up to 40 to 50 in much of the studies, whenever there is a multiple interruptions in adherence. So unless the patient is going to be very adherent to PrEP, there is no point in even issuing these drugs. You need to ensure basically at the counseling, they will able to take these pills every day without missing it. That's the backbone of this premise of PrEP here. If they keep missing the tablets, they will not be protected and they will have a breakthrough infections. They are at higher risk of even getting a drug resistant HIV. So these all need to be careful when you are issuing this. And few more things is there are 2 ways of prescribing. One is PrEP. Another one is we have discussed even is a demand driven or event driven. When there is an occasional involvement things, you can go for a demand or event driven, which is 2 pills just before 24 hours up to before the exposure, followed by 2 more days of pill taking. It's also allowed, especially for MSMs who are having anal sex. That is 2-1-1. That is a demand or event driven point. If somebody is only very conscious and know about everything, can go for it, and it's only when it happens occasional they can go for it. But somebody who is a very high risk, having a multiple exposures, better to go for everyday regimens rather than demand driven regimens. That is also, as discussed, it's only recommended in exclusively with your MSMs with uh, transgender women, not for most of other high risk groups here for event driven things. If not, basically you go for everyday regimen, tenofovir disoproxetil regimen. If it's okay for them, you can go for it. Other thing is you need to have a baseline HIV testing to be done for all these patients and do a proper counseling, and even you need to do creatinine, everything at the baseline. Rule out hepatitis B because whenever they stop, there is a chance for hepatitis B flare there. So always have the baseline. You need to have a HIV, hepatitis B testing with syphilis and STI testings. One problem that comes with, especially if they're high risk condomless sexual exposure, they are at risk still for STIs, in sexually transmitted infections. Though this PrEP will prevent HIV acquisition, they will not prevent any STI acquisition. So basic thing is still one of the risk mitigation is always go for condom, but there are maybe people who will not able to negotiate that. They are going to be risk at all this. So better to use this PrEP as an adjuvant therapy rather than, because it will prevent HIV if you are adherent, but it will still not able to prevent STIs. That's also you need to keep in mind. Then you need to carefully think whether the patient will need even STI prophylaxis in that particular point. Other thing is to simply use condom always. That is one very behavioral thing, but it's always proven to be much more effective than many of these. But the problem comes with the high risk behavior, with where the people who couldn't negotiate of use of condom, then PrEP is a very good alternative there also. So another thing is to, when after initiation of this drug, how long should they wait for the exposure? So ideally speaking, that will take at least 7 to 21 days. It ranges for the drug to achieve very good levels if you are on a daily prophylaxis. So anything at least for initial 2 to 3 weeks, better to always use protective behavior for you yourself to protect it. And you can stop PrEP from the last exposure at least. It also varies, but the recommendation sticks to at least 28 days from the last exposure. You can stop PrEP. PrEP is usually given every 3 months as a refill, because for them to have a continuity at the end of every 3 months, before reinitiation, it's always better to have a retesting for HIV and STIs if they are at a higher risk, to do all this testing again at that particular point. About injectables, it's easier, but only problem as of now, India is currently unavailable. Cabotegravir is once in 2 months, but you need a lead-in or loading dose initially once in a month, but after that, it's once in 2 months. But even lenacapavir, we have a very good advantage, is once in 6 months. And the other problem that overcomes both these drugs overcomes the problem of adherence with the daily preparations, because they can't, if they are continuously taking injections without interruptions, their levels are always high. Their breakthrough infection rate is going to be very less likely. Only problem, even if they're going to mismanage, or sorry, if they're going to interrupt injectables, the risk for either development of integrase resistance is going to be very high also, which we are seeing in Western countries as of now, not yet seen in India. So this is the brief summary of it. So another question is that especially when there are serodiscordant couples, the dictum is U is equal to U is equal to, that means undetectable is equal to untransmittable, especially in a discordant couple. But the problem comes, we can't ensure adherence in the one of the spouses always. So if they want to have risk-free exposure, either they should at least use condoms always, even though U is equal to U, that we know that if it's undetectable, it may not able to transmit, but better to always recommend condoms. If they're not recommending condoms, then there is you can use for PrEP for the partners. Carefully you need to choose, but if they are virally suppressed, no need. But if they are especially planning for children and all, even you can go for PrEP for the spouse, especially other spouse, even though they are virally suppressed, because we can't ensure always every day they are taking the medicine, they are adherent, and there is no breakthrough viremia present. So just to be on this very on the cautious note, we use PrEP, especially for a serodiscordant couple who wants to conceive. At that particular point, we can bridge with the PrEP. That's also that what most often the PrEP being used in India as of now. So that is one thing to take. I think even Dr. Moda can go on. Any other questions she can answer.
Thank you, Dr. Prashanna. So you have covered almost all the aspect of PrEP. One thing I want to mention, that U is equal to U, that is undetectable is equal to untransmissible. That should be always keep in mind. And another thing, if the patient is of a baseline hepatitis B, testing is mandatory, because whenever one person wants to give up the PrEP, then hepatitis B infection may flare. It should always keep in mind. Another thing is, whenever one person is taking PrEP, if he is taking tenofovir along with tenofovir disoproxil fumarate along with emtricitabine, or tenofovir alafenamide along with emtricitabine, then HIV testing is mandatory every 3 months. If one is taking PrEP regularly, if he is adherent, essential. It is very much essential to do the HIV testing every 3 months. And if it is injectable preparation for such as cabotegravir, it should be every 2 months. So it is very important to detect the HIV infection as early as possible at the beginning, very beginning, because there may be issue of drug resistance and there is an option to switch to antiretroviral therapy from PrEP. So I think you have covered, we covered almost all the aspects of PrEP, and I am handing over to Dr. Kulkarni.
Yeah, thank you, Dr. Prasanna Kumar sir and Dr. Modak madam. So there is one question I have noted on the chat box is that this is from Rajesh Setia. So his question is, husband is seropositive on ART and
Dr.
is
Kulkarni,
yeah.
Dr. Kulkarni, I have already replied in the chat box.
And
Okay,
one-
and Dr. Prasanna also.
One
Yeah,
thing, I have seen the question that say husband is seropositive and his viral load is undetectable, wife is seronegative. So as the viral load is undetectable, so it is assumed that it is untransmissible. So U is equal to U. So there is no indication of PrEP in this case. Only Dr. Prasanna has mentioned that condom use we always recommend for the safer side.
But the problem is, ma'am, Dipankar here. Problem is,
Yes.
if they were planning for a pregnancy, then condom use is
No,
not.
no. It is always recommended that they can plan for pregnancy. So condom use is not mandatory. It is not
That
mandatory.
only, and the adherence issue also is
Yes.
there. So, if the adherence cannot be assured, then probably we can think of giving some temporary that
It is not
TB
written in the
preparation also.
guideline that almost all the guidelines, CDC, Viva guideline, all accept that U is equal to U. I have seen so many pregnancies, fruitful pregnancies, when the serodiscordant partner is one is with undetectable viral load and the female partner is seronegative.
Okay, ma'am.
Okay, so there is one more question from Dr. C. Anandarao. How many copies per ml is taken as undetectable?
It depends. Actually, in Western countries, it may detect as low as 50 copies per milliliter. And in India, in our national program, it is around 1000 copies per milliliter. But in CDC guideline, it is recommended as 200 copies per milliliter. So it varies. So in India, according to NACO, we accept that less than 1000 copies per milliliter is considered as target not detected or VDL.
Okay, thank you, ma'am. There is another question by Dr. Anugada Shenge. So her question, discordant couple desiring for a child, can PrEP be used or U is equal to U can work for this couple?
Yes, U is equal to U will work for them and no PrEP is required if the partner is male partner is seropositive and has undetectable viral load, then they can plan for a pregnancy.
Right, sir. Dr. Prasanna Kumar, your
Yes.
views on this? Yeah. So just for as a discussion, because this was a panel discussion. Yeah.
Okay.
So this question is Anuradha Shenge that she's asking, there is a discordant couple desiring for a
So
child.
that is already answered.
Okay, so we'll take up the next question, sir. So this is from Ritin Mogagala. So if an asymptomatic patient comes for 1 week, comes for testing 1 week after the suspected exposure, or 4 weeks after suspected exposure, or 24 weeks after exposure, so this is also the question for Dr. Abhishek. What initial diagnostics test should we advise?
See, according to NACO, this patient qualifies straightforward as a strategy 3 testing. So if you have a strategy 3 testing, you have to go in for a serological test to begin with. And we follow the algorithm of a 3-test strategy. And depending on the results of it, of course, we must keep the window period in mind, the limitation that we have. But then now with 4th generation ELISAs coming up and the coverage of P24 antigens coming up, it's fair enough to stick to that. But we have to follow the strategy 3. for this particular patient who qualifies as an asymptomatic patient. So you have to begin with a 3-test strategy.
Can I add one thing? Basically, the question is if they come within a week of exposure, I don't think any of the tests currently available will able to detect, because there is a called eclipse period where you even the RNA to be detected, even if you do a sophisticated RNA testing for a patient, it will take at least 10 days to 15 days to reach a level for us to detect as of now. So I don't think anybody who comes to you within 2 weeks of last exposure, we don't have as of now any test that gonna pick it up as early as possible that time. After 2 weeks, you can use RNA testing, any molecular based nucleic acid amplification test will detect. Maybe 3 to 4 weeks, your P24 antigen, any fourth generation ELISA will able to pick up. More than a month to 1.5 months, your antibodies will able to come up. There, we can go for any antibody based testing. So within a week, I don't think we have any test as of now. You need to ask them to wait for them to at least 2 to 3 weeks if we go for RNA. Fourth generation ELISA has told you need to wait at least for 4 weeks, 3 to 4 weeks.
Otherwise, if you do the test earlier, it may give you a wrong impression that HIV negative, though it may be a case of HIV positive. So better to wait and to get the better result.
Thanks, ma'am. So there is a question, I think a follow-up question from Dr. Balaji Naik, which is the first test recommended and at what time?
This is a lead up to the previous question only, I believe.
I believe, yeah. So there is a question from C. Ananda Rao. He wants some information on sperm washing, as many educated couples are inquiring about it. Many educated serodiscordant couples are inquiring. So maybe Dr. Prasanna Kumar or Dr. Modak can suggest.
See, we have discussed that one because see the chances of when the partner is completely suppressed, there is no need for you to do any of these sort of things. It's not necessary completely. It is 99.9% proven is equal to you. See, when you want to be too extra cautious or precautious, you want to do all this, but this is completely unnecessary. You don't need to go for all this if you stick to it. Only thing is that maybe risk categorization is differ, but always if the partner is adherent throughout, and that is definitely not possible for them to transmit, so you need not to go for this foam washing. Any other techniques no need to be adapted. But maybe in my perspective, I might want to slightly differ from Dr. Moda, because many times we may not know the adherence of the other partners also. Whenever that is a problem for me, then I would advocate PrEP for the other partner. Sometimes as a part of a risk stratification, when the partner, we can't ensure the partner adherence throughout when they are planning for a concern. But for all practical purpose, you can stick to is equal to you. But is an extra precaution, maybe over precaution, you may call it, but it's worth in some patients who are very apprehensive of contracting when the partner can't ensure adherence.
Yes, sir. Thank you. Thank you very much. So there is another question, I believe. So there is a couple where husband is positive and wife is negative, where husband is virologically suppressed.
It was
So-
already answered.
Yes.
Yeah. Yeah, just we'll continue for a few more things. So, just wanted to ask the panel about the eligibility for PrEP, which for whom the PrEP can be offered.
Dr. Moda,
PrEP can be offered to any active adolescent and onward man, woman, transgender, and bisexual, gay, MSM. So it can be offered IDU. It can be offered to all who wants it. So it is a very good option to prevent the HIV. It is one of the most important pillar to prevent HIV infection. So it should be offered whenever anybody wants it.
Right, ma'am. So nowadays, do patients are asking the physician that they need PrEP? Means how is the awareness of this?
Awareness is there, but it should be promoted in a greater aspect. Mostly the educated persons are coming in our clinic that they want PrEP. And sometime, and because it is important, very important to do the baseline HIV testing and so many things to do. But in the general population who are HIV infected, mainly in the society, the migratory laborers and the general population, there is lack of awareness. So it should be promoted. And the NACO is also not accepting the PrEP protocol till date. So in coming future, probably in NSCP 6, NACO will adopt the PrEP. Because NACO is still is not recommending PrEP. It is not in their NACO protocol till date.
Ma'am, sorry. I think NACO has come up with a policy guideline with an endorsement. There is a policy guideline, but they have not yet provided drugs
Yes.
made available to the eligible participants. But the government has basically endorsed a policy document is already available, maybe 2020. They published stating that the government wants to implement PrEP. Only problem as of now, they are not providing drugs
Yes.
as of now through NACO for PrEP initiation. That's where the problem lies because it needs a lot of money, everything.
Yes, that's why it is
working
there.
on it. It may come, but
It will
government
come soon.
endorsed as a policy brief. Government is endorsing PrEP as a mean to prevent and reduce HIV incidence.
Definitely.
Yes, sir. Dr. Prasanna Kumar, your views on PrEP in India and in your setup, sir.
Yes, whoever asks, we are prescribing because but the awareness, as ma'am also spoke, is not that great. Especially it depends on the awareness because it's as of now it's not freely available. It's only whoever wants to pay for it. They needs to pay out of the pocket. It will not come through insurance anything. And as I said, many of the times it's also depends on you need to approach a doctor, get counsel, get tested baseline, then drug. Everything matters. So as compared to any other Western countries or US, the PrEP uptake or initiation in India is very, very poor and marginal. Maybe the awareness we are not has gone. Basically, we have not made a huge awareness about PrEP. Maybe in one way to look at, I don't know whether they are feeling we will promote promiscuity in the society. That also a problem. Whether you say that you take it and you can do whatever you want, so there are pros and cons to it, but as a public health initiative, it's up to the, as of now, it's balls in the court of the people. But the problem is, I think there is quite lack of awareness. We as a medical community, we need to reach out to them to create awareness because it's a mean to cut the incidence when we want to prevent transmission from acquiring people. It's always better to prevent HIV acquisition rather than to treat them lifelong. So we need to push more into it. I think both money and efforts needs to go into it as part of prevention, what I feel. But I feel it is totally completely not up to the mark or expected level of PrEP is in India. We are, because even the doctors part, their awareness is quite lacking. So only few areas who are really interested in ID or HIV medicines they are promoting, except for them, because most often they can't have access to these kind of allied or like specialized doctors. So every doctor should be made aware the PrEP role of PrEP, like government has made it a ART. The best way to do it, government can push through ART centers. It's easily doable because government, every center, every taluk, every area has now an ART center in India. If government pitches in, it's easier and able to do in a great successful way, I think.
Yes, sir. So thanks for your feedback and your experience, sir. So I think that now more questions are coming. So what I can do is that I'll just propose a short vote of thanks. So this was a very illuminating webinar, and here we had got many topics today, and I would like to thank all the speakers for sharing their valuable insights and also uh, giving the advices for the few questions which came up today. So on behalf of MCO Pharmaceuticals and And also, one more thing that I wish to thank Dr. Dipankar Pal sir. So though he had a family exigency, he could join for a short time. So thank you very much, sir. And I thank Dr. Dolan Modak madam, Dr. Abhishek Sen Gupta ma'am, and Dr. Prasanna Kumar sir for sharing your valuable clinical pearls. So thank you all. Thank you so much, and
Thank
have
you,
a
sir.
great evening ahead. Thank you. Thank you all.
Thank you.